All right, good morning, everybody. Obviously, you can tell this is Professor Amador. I'm here with one of my phenomenal students, Diana. Right behind the camera is Adriana. So Adriana and Diana
good morning.
Are going to help me put some of this together for you this morning. So we are going to show you how to do the special test of the upper extremity. We're going to cover the shoulder and the elbow. Some things to think about. Anytime we are looking at special tests or doing special tests, we have to remember our friend Dr. Carmona, and we need to think about the anatomy of the special test. I'm not going to do that. That's not going to be what I'm attempting this morning. We will go over that in class, but I do want to show you how the test is done. So in your own time, if you want to spend some time with this, obviously the video will be there for you. Okay, so here we go. So the first test in your class notes is a shoulder apprehension test. Shoulder apprehension test. The word apprehension denotes that I, the examiner, is doing something in somebody else. In this case, the patient or the subject is apprehensive about whatever it is that I am doing. The history here, probably the history on the patient, would probably allude to some kind of a dislocation. So thus the test, shoulder, so thus the name, shoulder apprehension, anterior or posterior dislocation. So there's an anterior component and a posterior component. I'm going to show the anterior component first. So for that, Diana is going to lie supine. And all I'm doing is, since I want to place pressure or I want to place a force over the anterior structures, I am going to externally rotate. So the shoulders abducted, and I am going to externally rotate. As I externally rotate, the head of the humerus is going to move anteriorly, and put pressure or exert a force over the anterior aspect of the capsule. Apprehension test for an anterior dislocation. We can also, Diana, can you move towards me a little bit?
Sure.
We can also bring the arm up in this position, leave some room for Adriana to be able to get that. Place my left hand behind the shoulder and exert a force posteriorly through the arm, posteriorly, for posterior dislocation. In both of these tests, anterior, the patient would be apprehensive, that would be the direction of dislocation. Posteriorly, the patient would be apprehensive because that's the direction of a posterior dislocation. Okay, so the second picture that you have is a Speed's test. So the Speed's test is a test for biceps tendon pathology, and it says / tendonitis. Obviously, tendonitis and inflammation is going to cause pain. In this case, the description is as follows. Examiner, that's me, resist active. A is for active shoulder flexion. So I resist active shoulder flexion. The examiner also stabilizes the shoulder or places the hand slightly anterior so I can feel what's happening with the biceps tendon as I resist the motion. So the motion is going to look, the motion from the subject is going to look like this, or it's going to be in this direction. I place my hand in front of the shoulder, and now I am going to resist the motion and ask Diana to bring her arm up. Go ahead, Diana. There we go. Something else that we could do, so I had my hand over the shoulder, feeling for crepitus, feeling for the tendon gliding through the groove. Another thing I could do is I can bring my hand slightly out and just place my fingers right over the groove and do the same thing. Diana, go ahead, bring the arm up. And that is the Speed's test for biceps tendon pathology or tendonitis. So I'm warming up. I'm a little less camera shy now. I'm reminded that I have to do a good job so I can look as professional as Dr. Melendez does in all of her videos. So here we go. The next test is the Jorgensen's test. This is another biceps tendon pathology, tendonitis test. And we're looking, in this case, we're looking at, or I'm asking the examiner, sorry about that, I'm asking the subject. You don't have to edit it, Adriana, we're good. I'm asking the subject to bring the arm out in this direction. So we are externally rotating the shoulder and supinating the forearm. So it looks like this, from here to here. I, the examiner, is going to resist that motion. As I resist that motion, I am creating a force which forces the biceps, obviously, to contract. Remember, the biceps is a strong supinator. Should there be a problem, should there be pathology of the biceps tendon, we're going to get the same results as on the previous test. We're going to get somebody who complains of pain. So it's going to look like this. I place my hand anteriorly, fingers over the groove, and I ask Diana to bring the arm out, and I resist that. Go ahead, Diana. Bring the arm out. Bring the arm out. Let's try that one more time. Let's do it with force. Out, 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 out. And that is the Jorgensen's test. Okay, so next we have the drop arm test, which is a test that aims to identify a rotator cuff tear, should there be one. The key here is if there's a rotator cuff tear, obviously it's going to be more difficult for the rotator cuff to generate enough force to control the arm. That's the key to that test. This test can be done two ways. It can either be done sitting, as Diana is now, or the test can be performed standing. For the purpose of the filming, we're going to keep it in sitting. So what I'm going to do is I'm going to ask Diana to bring her arms up to the side and then slowly bring them down, nice and controlled. Diana shows you have no pathology, but now Diana's going to mimic, should there be a pathology or a problem, rotator cuff tear of the right side. In this case, on the way down, Diana's going to have a hard time controlling that. Let's do it one more time so we can show them what that looks like. On the way down, she can't control it, boom, and there's the possibility that it could be painful. Okay, so the next two tests are going to be impingement tests. And in this case, what are we impinging? Well, we're hoping to impinge anything that's under the acromial arch, and particularly in the Hawkins-Kennedy, is described as a supraspinatus impingement test. The way the test works, and hopefully we can film that in a way that makes, there we go. The arm is brought up to about shoulder level and across, so that's a bit of adduction, and then we internally rotate. It looks like that. There are different ways to do this test as well. One thing, or a different way of doing it, is I can stand behind Diana, and I can stabilize the shoulder, in this case a little bit better, come across and do the same thing. Adduct, internally rotate, adduct, and internally rotate. If Diana was to have an inflamed or involved supraspinatus tendon, Diana will most likely complain of pain when sometimes even as simple as adducting, internally rotating is just rubbing that tendon or the cuff, even more so across the acromial arch. And that describes the Hawkins-Kennedy supraspinatus impingement test. Diana did have some, this is just a little bit of adding here. Diana did have a little bit of crepitus, but that would not be enough for me to say that she has a positive supraspinatus impingement test. So the next impingement test, supraspinatus impingement test, is the Neer's test. And this is a very popular and commonly performed test in the clinic because it's very simple to do and the anatomy is very simple to follow. I'm not going to go over the anatomy because, here, because I'm going to expect you guys to review that on your own. But in this case, what we're doing is we are bringing the arm up. I like to even externally rotate the arm just a little bit, and we are compressing the greater tuberosity against the acromion, right? Again, the acromial arch, as we maximally flex the arm into what? Or move the arm into shoulder flexion. So the arm comes up as far as we can take it into shoulder flexion. A positive impingement test, the patient would complain of pain. Okay, so we're still with the Neer's test. Passive shoulder flexion. My left hand is placed behind the shoulder, over the scapula, providing a stabilization force against flexion. So the next test is called a supraspinatus test, or empty can test. And the reason why it's called empty can, if I was to hold a can in my hand, imagine I have a can in my hand and I internally rotate the arm, of course I'm going to empty the contents of the can. So supraspinatus, or empty can test. I asked my patient, or in this case, my student, Diana, to bring her arms up and slightly to the front or scapular plane. She internally rotates the arm, and I place a force. I either can stand in front, or if she was standing, go ahead and stand, Diana.
Okay. Or
if she was standing, which I think I like a little bit better, if she's standing, I then stand behind her and I can exert more force. If Diana, you're good, have a seat.
Thanks.
So if there is a involvement of the supraspinatus tendon, suprascapular nerve, if it was suprascapular nerve, she would have a tough time. Obviously, she would have weakness maintaining the position. If it was the supraspinatus tendon, it would probably be more pain than actual weakness in this case. And that completes the supraspinatus empty can test. So the next group of tests are for the elbow. In this case, we have the Valgus and varus tests of the elbow. They are tests that are performed in order to determine if there's laxity of the either lateral collateral ligament or medial collateral ligament. It is key when assessing laxity to test bilaterally. I'm not going to show you guys bilaterally for the sake of time, but it is imperative that we check bilaterally to note if there's a difference from one side to the other. So the first one I'm going to do is the valgus. So the elbow is going to be placed in slight flexion, and I'm going to say somewhere around 20 to 25 degrees. We don't have to be exact. And the force is going to come from the left hand or the left arm in this direction, and we call that the valgus direction. So my hand goes behind the elbow. This hand can be either on the forearm or on the hand. I prefer the hand, and I am going to apply a force with the left arm or left hand in that direction. Valgus test. So envision the medial collateral ligament running in this direction. As I apply a force like this, I am actually causing that ligament to stretch. The valgus test of the elbow. I'm going to keep going, Aliana. The varus test of the elbow, same elbow. I'm going to stand in front of my patient. The arm is exactly, again, open pack, 20-25 degrees. My right hand, in this case, is on the medial side, and the force is towards the outside. So medial side, force towards the outside. And Diana is not showing any laxity whatsoever. She's a young, strong woman who does all kinds of exercise and stuff that keeps her ligaments healthy. So varus test, varus direction. So the next two tests, we have a tennis elbow test and we have a golfer's elbow test. So in the tennis elbow, lateral epicondylitis, the problem or the pathology is on the outside, common extensor tendon. In the golfer's, so tennis, backhand of tennis, in the golfer's elbow, the next test I'll do them consecutively. The problem is on the medial aspect, right, or common flexor tendon. Two different tests testing the muscular integrity of the form. So Diana, I'm going to tell you what I'm going to do. In this case, okay. I want your arm or your elbow extended, okay. And then I want your wrist extended as well, right? I'm going to stabilize at the elbow, and I am going to resist that movement by placing a force over the hand. So here we go, Diana. Ready? Mm-hmm. And should Diana have this case, tennis elbow, she's going to complain of pain over the lateral aspect, or again, the common extensor tendon. The other test, the golfer's elbow. So let me go back for a minute. This test is a resistive test. The next test is a passive stretch. Again, muscular component, elbow extended, wrist, elbow extended, arm supinated, and wrist maximally extended. This is placing a force. Diana should be feeling this to be getting somewhat tight as I extend the elbow, supinate, and extend the wrist. Should she have a problem, right, what we term golfer's elbow, she would complain of pain over the medial aspect of the elbow at the insertion of the common flexor. Okay, hopefully that makes sense. Let me say it one more time. Supination of the extension of the elbow, supination of the forearm, and extension of the wrist with pain over the medial side. The last test of the elbow is a neuro test, right? Testing the integrity of the ulnar nerve. The ulnar nerve runs between the olecranon and the medial epicondyle. There's a groove. All of us know where it's at because when we hit ourselves in that area, we get that little tingling. So I'm not sure about the reliability of this test. It's not one of my favorite ones, but it's called Tinels test of the elbow. And all I'm doing, and I promised Diane I wouldn't be doing it, that I am tapping in that area between the olecranon and the medial epicondyle of the elbow. And I would tap and you would get tingling along the distribution of the ulnar nerve, which is 1 1/2 fingers, the little finger here, the pinky, and half of the other. I always get a positive test, and I've lived to be 55 years old, so I think you guys will be okay. Yeah. All right? Yeah. Thank you.